Thank you, John. So I will talk to you about the fundamentals today. I don't have any relevant disclosures. And the objectives is to describe the elements of the fundamentals that SAGES has created, identify the ways that they may help you improve the safety of the surgical care and the quality, and how perhaps you might consider implementing them in your program. I'm not going to talk to you about religious fundamentals or about Mike Scott's fundamentals, which are very interesting. I'm going to talk to you about the SAGES fundamentals, which many of you are familiar with, the FLS for laparoscopy, FES for endoscopy, and FES for energy use. So many of you may be familiar with this, but I'll go over them briefly if you're not very familiar with them. But FLS is essentially a comprehensive web-based education module that also includes a hands-on skill training component and assessment tool, and it is designed to teach essentially the skills required for basic laparoscopy. There are 4 online education modules that relate to preoperative, intraoperative, postoperative care, etc., and 5 simulated tasks, which are depicted here, the peg transfer, the pattern cut, the endoloop, and the 2 suturing tasks, extra and intracorporeal. And there's also, of course, a high-stakes assessment that consists, number 1, of a cognitive part, a multiple choice exam, as well as performance on these 5 tasks. The fundamentals of endoscopic surgery is again a similar program that's a comprehensive educational and assessment tool, and it is designed to teach and evaluate endoscopic skills as well as knowledge about endoscopy at the basic level. This program consists of 12 online education modules, which are free, but it also has a high-stakes exam that includes, again, a cognitive test as well as a simulator module. It has actually 5 modules, but it's a simulator that you have to use. It's a virtual reality, and you have to perform 5 tasks that relate to some of the fundamental endoscopic skills like navigation, loop reduction, for example, when you do colonoscopy, evaluation of mucosa, retroflexion, targeting, etc. The fundamental use of safe energy, the FES program, again, is educational and is designed to certify a successful candidate that has demonstrated knowledge on safe use of energy in the operating room or related to any procedure. There are 10 online education modules, and there's a high-stakes exam at the end. This, at this point, doesn't really have a hands-on simulated piece, but actually some things are being developed. So, given the topic of this panel, I will try to address a little what evidence we have that demonstrates that these fundamentals may be improving the quality or the safety in surgery. I will start with this paper, one randomized trial that essentially assessed performance of trainees, put them through a proficiency-based curriculum using the FLS tasks, and assessed also their performance in the operating room before and after the intervention, and demonstrated that compared to a control group, performance improved 3 times more in those trainees performing a laparoscopic cholecystectomy who did have FLS training prior to that intervention. So this GOLS is an assessment tool that has been validated for the assessment of laparoscopic skill, mainly basic laparoscopic skills. And you can see that the ratings by expert observers improved significantly and a lot more so in the intervention group. So that's some evidence that by doing the tasks, you get better in the clinical environment. I also pulled this paper because it demonstrates that when you take the tool, take the FLS, and you put your surgeons, practicing surgeons this time, through test, what you find is that 1 out of 3 fail the exam, which is a little scary because these surgeons are using laparoscopy, and actually even 13% failed the FLS certification exam even after some training, which wasn't that long, but nevertheless, it's still important. So within the study that was performed by one institution, Amy's institution, there was some improvement in performance demonstrated even after a few hours of training. Finally, this article was published last year, but it demonstrates that this different perspective of how you can use FLS to improve training and implementation in your practice of a new procedure. This is best studied in underdeveloped countries, just because the way we evolved FLS came after the introduction of the new technology, whereas in this particular experience in Botswana, there was a hospital that wanted to introduce laparoscopy. The surgeons were not doing laparoscopy, and they used a training program that included FLS as part of gaining laparoscopic skills. They also had proctors that helped them for the initial case, but they were able to become essentially independent laparoscopic surgeons over a period of years with the use of FLS. Yes, FLS was part of the whole process, but it definitely contributed to the training and the skill. And of course, they had about a 5% conversion rate. The length of stay decreased significantly from 7 to 1 days. And as I mentioned, eventually they were performing the procedures independently. So how about endoscopy? FES, as you probably know, is something that recently has been introduced. So the experience, unlike FLS, is not that huge. However, there's clearly a number of arguments of why it's needed. So as you know, especially if you're responsible for the training of residents, there are many programs that struggle to achieve the necessary numbers for the residents to graduate. There's also, if you're following the literature, a few years ago, GI societies put out a statement saying essentially that you have to do a large number of endoscopy cases to be considered good, which is actually beyond what most surgical programs can offer. Endoscopy also constitutes a large part of general surgery practice. If you look at statistics, it's maybe up to 1/3 of what many general surgeons do in the community of their practice. And there's no question that ensuring a better competency of graduating residents in endoscopy will ensure better quality. I think we would only agree of how we take care of our patients. And I would make the argument that FES, the platform that SAGES has developed, provides the platform to achieve all these goals and address all these issues. One study that has looked at FES and correlated the metrics you get from the FES when you do the tasks on the simulator to observations clinically while you're doing a colonoscopy. They found essentially there was a very strong correlation between the metrics, which is an indirect way to demonstrate the relevance of FES for clinical practice. I'm sure as we move forward and FES becomes more commonplace, we'll see a lot more evidence come out on its utility, as has happened with FLS. At North Carolina, we do have a study going on where essentially we are currently enrolling residents, have enrolled residents in all our training programs, and we're generating a curriculum for the fundamentals of endoscopic surgery using the FES test as an assessment tool at the end. but also obtaining clinical evaluations. That will give us some additional information of how to better do this. So how about FES? The approach to FES started with a needs assessment, and if you look at the needs assessments, there's a couple of papers that have been published, one here from the US, one from Japan. Based on the data and the findings, less than 10% of surgical trainees really know what the best practices of surgical energy use are. And even surgical leaders have a problem, as the first paper that was published found that even SAGES leaders, only 60% knew the correct answers to a test that they were given before training in this. So I mentioned earlier that simulation has not been very much embedded yet in this, but actually there is a study that has used a simulated approach to teach people how to use FES, the cognitive material, training material that's available. And it did demonstrate improvement, which was a little better than that of a control group. Clearly, just putting someone through the didactics, their ability to understand and their knowledge essentially doubled. And with simulation, there was a mild higher increase in ability. So the last thing I'm going to address is how to implement the fundamentals. Well, there's a number of things you do need. There's no question about this. You essentially need an organized approach and probably a skills lab or a bigger simulation center. It's not, for someone who's new in the simulation arena, the usual thought process is, I'm just going to go get the simulator and that's going to take care of it. And all of us who've gone through that phase early in our career know that that definitely is not true. So you don't just need the simulators, you need a lot more things to make the simulators have value in the training of your program. You need the people that will make sure the trainees come and do the tasks, faculty to instruct, provide feedback. You need the space to put the simulators, you need the supplies, especially the FLS requires supplies. You need protected time for your learners, otherwise they may never go and use those simulators. You need a curriculum, probably the most important thing. At this point, at least in the literature provides a lot of examples of how to best use these simulators, mainly for the FLS, but more will come out for the FES and as I showed you the study we're doing, for example, and for the FES. SAGES provides a lot of research along those lines. And of course, there are also assessment tools and metrics available that can incorporate into this process as you're assessing the skill of your learners to make sure they're getting to where you want them to get in their abilities. And of course, there's also the opportunity to take the tests, FLS, FES, and FES, to demonstrate your competency. We'll get to the questions in a moment. Thank you.